Folks, welcome to the conference. I hope that you're enjoying it, that you're learning. And we're going to learn some more today from Dr. Maria Cabanillas. She, in fact, is my MD Anderson endocrinologist. So we know each other quite well. She's an oncologic endocrinologist at MD Anderson in Houston. She's a professor, faculty, and director of clinical research in endocrine neoplasia at MD Anderson. She treats all kinds of thyroid cancer, including some very advanced and complex cases, which is one reason that I went to see her, because I had lung mets. And I'm not getting my treatment there or anything, but it's wonderful to be able to go to have consultations with people like Dr. Cabanillas at MD Anderson or some of the other major institutions. She's done a lot with immunotherapy, looking at new medications and new treatments, and has talked about those extensively at prior conferences. You've been coming to these things for how many years, Doctor?
Oh, I've lost track.
Yeah.
I can't remember. I'd have to go look at my slides to see when my first presentation was.
Yeah, I've been coming since 2002. In any event, she's a member of the International Thyroid Oncology Group since 2012. You can tell I saw your bio on the MD Anderson site. And you're currently on the board of directors of that group.
I just finished my 3-year term. I just finished my 3-year term, so no longer, but close enough.
Excuse me. Without any further ado, then, I'm going to turn this over. She's got a lot to talk about today.
Okay, so we're going to talk about radioiodine refractory differentiated thyroid cancer. And, you know, I'm not going to, this is a pretty long talk, so I'm going to try and go through it without kind of focusing on things that you're probably already aware of, which is that, you know, the incidence of thyroid cancer is rising. It's more common in women than men. We usually, we see patients basically that are, you know, young in their 20s, but the peak incidence is in the mid 40s to 50s. And then there are there are several different types of differentiated thyroid cancer, which are the majority of all thyroid cancers. There's papillary, follicular, Hurthle cell, and poorly differentiated. The poorly differentiated is derived from one of those first three, papillary, follicular, Hurthle cell. Sometimes we can't tell which one it derived from, and sometimes we can. But anaplastic thyroid cancer, thankfully, comprises a very small sliver of the total number of thyroid cancer patients. And then medullary thyroid cancer, also rare, but not as rare as anaplastic thyroid cancer. So this is, I used this in my last talk, and so some of you who are in that talk are seeing this again, but thyroid cancers are derived from the thyroid cancer cells. The well-differentiated thyroid cancers, again, are papillary, follicular, Hurthle cell. And these have particular mutations. And then once these tumors start to acquire new mutations, they become more aggressive and can be poorly differentiated thyroid cancers, and then left long enough in the body can become anaplastic thyroid cancers. We sometimes can see just, you know, what we call de novo anaplastic thyroid cancer, which basically is just a follicular thyroid cell that all of a sudden transforms to anaplastic, but it's very rare. Usually they come from a well-differentiated thyroid cancer that the patient didn't know that they had, or they had a past history of let's say, papillary thyroid cancer, was treated adequately, and then the tumor came back. Sometimes, you know, patients are not aware that the tumor has come back, and then that has the potential to transform to a more aggressive form of thyroid cancer, namely poorly differentiated and anaplastic thyroid cancer. But poorly differentiated is considered a differentiated thyroid cancer, whereas anaplastic is considered an undifferentiated thyroid cancer. So the initial management of differentiated thyroid cancer is we remove the thyroid. Sometimes we only remove the side that's affected, especially if we're not going to give radioiodine. But in most cases, the full thyroid is removed, and any kind of lymph nodes that are involved in the neck, then we give radioiodine to patients who have intermediate or higher risk of having the tumor come back. And we put them on TSH suppression. We can sometimes repeat that radioiodine, sometimes repeat surgery when needed. And then our tumor marker is called thyroglobulin. This is a protein made by thyroid tissue, not just thyroid cancer. So for example, if they only removed half of your thyroid, you're still going to have quite a bit of thyroglobulin because you still have half of your thyroid. So we use thyroglobulin as a marker to know whether, we kind of use it to know where you're starting out at. So if your thyroglobulin after surgery, full thyroidectomy is 100, we know that's too high. You shouldn't have a thyroglobulin that high. So it gives us an idea of the amount of disease you have. And then we use it dynamically also, meaning every time you come to a visit, we check your thyroglobulin. If it's going up, we know there's something going on. We need to find out where that's coming from. And if it's going down, then we all are very happy and satisfied that things are stable or better. I should mention, though, that not all patients make thyroglobulin, and that can be a problem, especially in poorly differentiated thyroid cancer, where you don't have that marker. Okay, so in terms of prognosis, the vast majority of patients are going to be cured with that standard care, the surgery, radioiodine, TSH suppression. This staging actually needs to be updated because the age limits are higher now. But essentially, papillary thyroid cancer patients do the best. Follicular Hurthle have a little bit higher mortality. And then patients with disease that has left the neck, so we call that metastatic disease, widely metastatic, meaning that it's in a different organ. Those patients have the worst survival, but still 10-year median survival is around 42%. And then age matters, the pathology matters on that tumor, where those metastases are located matter, the size of those metastases, and the response to radioiodine also makes a difference in terms of prognosis. This is an example of a patient who was diagnosed at age 17 with papillary thyroid cancer with lung metastases. The patient then had radioiodine and had really good uptake in the neck and in the lungs. And this is the patient at age 53, little tiny lung nodules, patient still alive 36 years after the original diagnosis. So the age at which you were diagnosed is actually quite important. Those patients usually do better when they're diagnosed earlier, at a younger age. The PET scan is sometimes helpful. So we know that patients that take up a lot of the tracer, the FDG tracer on PET scans, actually don't do as well as patients who don't, because what this shows us is that this is a tumor that's very active. It's very actively trying to grow. And so, and then it also usually has an inverse correlation with the radioiodine uptake, meaning that many patients who have a lot of uptake on the PET scan, the FDG PET scan, will not have a lot of uptake for radioiodine. Okay, so let's define what radioiodine refractory means. Basically, if the patient has no radioiodine uptake anywhere, which is this first picture, the red means no uptake, the black is uptake. That patient, and you know that they have metastases in these areas, and that patient has radioiodine refractory disease. If the patient has one or more lesions that don't take up radioiodine, so see this patient took up in 3 spots, but not in 1 spot, that's radioiodine refractory. If the patient does take up radioiodine, but those tumors start to grow within 1 year, then that's also considered radioiodine refractory. And then The patients who've just received too much radioiodine, we consider those radioiodine refractory, even though it doesn't mean that they won't respond to more radioiodine, but we try not to go over a certain limit. Different doctors have different limits. My limit is somewhere between 600 and 800, but there are physicians who treat at much higher doses, and there are physicians who won't treat over 600. So it's a little bit arbitrary. For clinical trials, we usually use a cutoff of 600. Okay, so what do we do about patients who have metastatic disease? Because, you know, the vast majority of patients are actually going to be cured with just surgery, radioactive iodine, and TSH suppression. Minority are going to have still active disease, but not all of it has to be treated. Not all of these patients need to be treated. So there are three approaches. One is watchful waiting, which I know patients don't like. The majority of patients don't like, but the reality is that oftentimes these tumors aren't going to hurt you. And sometimes the treatment can be more harmful than just watching and waiting. Localized therapies, this is patients who we can sometimes deliver a dose of radiation. For this, in the picture here, it's showing a bone. It might be a lung metastasis that's just one metastasis that's causing problems, or it has the potential to cause problems that we might give radiation to. Embolization is where we inject something to make the tumor blood supply shrink, to make the blood supply be cut off, and then the tumor shrinks. Surgery, in some situations, if there's a metastasis that's causing problems and everything else seems to be pretty stable, we can sometimes just remove that metastasis. One of the things that's not on here is alcohol ablation, which we can do in the neck for some patients. And then we have the kinase inhibitors, which will be the majority of what I'm going to talk about today. So why do we watch and wait? Well, because a lot of patients have metastatic disease that just doesn't grow. And it has a very long period of no growth. And then sometimes at some point it does start growing, and then you can start treating them. But sometimes that could be 10 years, you know, and so you're sparing the patient 10 years of chemotherapy, which is pretty good in my opinion. It might be 1 year, it might be 2 years, but it's still a good amount of time usually. There are quality of life issues that are related to treating patients. These kinase inhibitors, they do have side effects. They not only have side effects, but sometimes, you know, we have to actually stop the chemotherapy because the patient can't tolerate it. And so, you know, then you're stuck with the problem. It's like, well, do they even really need to be on treatment at all? And so then you're back to kind of watching and waiting. We've not really cured many patients with kinase inhibitors, and that's a problem. And the other issue is that these drugs can be very expensive. This is a menu of localized therapies. I'm not really going to go over this, but because I already talked a little bit about some of these localized therapies, but I wanted to point out that patients who have bone metastases may also be candidates to receive bone modulating drugs. And I know that there were lots of questions about bone metastases in my last session, so I want to point this out, is that, you know, we can put patients on these drugs that are approved for patients that have bone metastases to try and put those cells kind of to sleep. And so that maybe they won't cause as many problems for the patient. So who are the patients who actually need to be on some type of chemotherapy? Chemotherapy can mean also kinase inhibitors. It's not just the kind of chemotherapy that makes your hair fall out. So patients that have disease that's just confined to the neck, we prefer to operate on those patients and take that out. But sometimes that's not possible. And this is a picture here showing you the tumor right here. And the tumor is invading the tracheal wall. You'll just have to believe me on that. And so, you know, some surgeons might be able to remove, you know, parts of that, of the tracheal wall to remove the tumor, but oftentimes you can't. And so those patients will need some kind of systemic treatment. We also really worry more about patients that have fast-growing tumors or tumors that are on the larger side, meaning it's kind of arbitrary, but 1.5 centimeters or greater. But, you know, I've left in larger tumors that just aren't growing. And so we just kind of, you know, leave them be or send them for ethanol ablation. If they're small enough, there are some size limits there. So not everything needs to be treated with chemotherapy. Patients who have metastases that have left the neck, so they're what we call distant metastases, meaning it's gone to another organ. The criteria that we use for starting chemotherapy is tumors that are larger, so what we call clinically significant disease, which is, again, arbitrary. It's about 1.5 centimeters, greater than 1.5 centimeters. I usually use 2 centimeters as my, not 10, 2 centimeters as my cutoff. And then how quickly the tumor is growing. So if it's growing within 6 months, that's a very aggressive growth rate. Sometimes within 12 months, we'll treat also. If the disease is causing symptoms, we like to treat those patients. Diarrhea is not a symptom that you would have with differentiated thyroid cancer. It's a symptom that you would have with medullary thyroid cancer, so you can just ignore that diarrhea there. Those are the perils of repurposing slides. Metastatic sites that you can't treat with localized therapies, the ones that I mentioned before, for example, radiation. And then if this tumor is in a spot that's going to cause problems. So for example, a tumor that is very close to the airway, that if it just grows a little bit more, that patient's going to have problems. They're going to develop pneumonia, you know, behind that tumor, and these can be recurrent issues. So we're going to just talk briefly about targets. With this talk, I used to kind of go into more of the mechanisms of action of these drugs, but this year I'm not going to do that just because it is quite complicated, and I'm not sure that it matters very much. But anyway. What you do need to know is that mutations and fusions are really what we are looking for in patients to try and find the best treatment when they need a systemic treatment. So a mutation is just when the gene is damaged, and then that causes the genetic message to be altered, and then the tumor is allowed to grow. A gene fusion is basically a fusion between 2 genes, and then one gene tells the other to allow the tumor to grow. It's a little complicated, but mutations and gene fusions are what we're looking for to find a very specific targeted therapy in some patients. In others, we don't find anything that we can actually target, and so we use kind of the general mechanism of tumor growth in cancer, which is trying to target the blood supply, right? Because these tumors try and steal the blood supply. They make little tiny blood vessels so that the tumor can keep growing. And if you can just prune those, the tumor will shrink. And these cannot be passed on to the next generation. Whereas in medullary, those patients, some of them can pass the gene on to their children, and then those children will develop tumors too. But that's not the case for the most part in differentiated thyroid cancer. Okay, so the most common mutations in differentiated thyroid cancer are BRAF and RAS. BRAF occurs in papillary thyroid cancers and poorly differentiated thyroid cancer and anaplastic. RAS occurs in follicular thyroid cancers and a minority of papillary thyroid cancers, and in poorly differentiated thyroid cancer and anaplastic. The gene fusions are seen in papillary thyroid cancer. And so this is just showing you the different drugs that we have and this really needs to be updated, but for BRAF, we have BRAF inhibitors. For RET, we have RET inhibitors. We have much better ones now than these that I'll talk about. And then, you know, for some RAS mutations, maybe tipifarnib might work, but that's a drug that's not even FDA approved. Okay, so what about these novel, specifically these targeted therapies. This is a very much, it's a growing list. The last year there were only five drugs on this list. So it's kind of nice that I've been able to add another 2 drugs this year. But this is our kind of our menu of kinase inhibitors that are, because these are the approved ones. We can use non-approved kinase inhibitors, but these are the ones that are approved. So we have sorafenib for differentiated thyroid cancer, lenvatinib for differentiated thyroid cancer. We have drugs that target NTRK and target RET, and I'll talk about those later. We have vandetanib and cabozantinib for medullary thyroid cancer, and then dabrafenib and trametinib for BRAF mutated anaplastic thyroid cancer. So, you know, when I first started giving talks at ThyCa, there were no drugs approved for thyroid cancer. So come a long way. Just so you understand what I'm showing you in terms of, or if you want to go and read about certain, you know, kinase inhibitors that you might be interested in or that you're going to be on. If you read the literature, you're going to see something called waterfall plot, which is basically just shows a bar as each patient. And this is the amount of tumor shrinkage they've had since going on the chemotherapy. So this patient had a little over 60%. This patient had 100% tumor shrinkage. We cut off at 30% as what we consider a partial response. So this is the data for sorafenib and lenvatinib. So sorafenib had a 12% response rate. Lenvatinib was much higher, 65%. Lenvatinib is a much more potent drug than sorafenib, which sometimes is a good thing and sometimes is not a good thing. You can have bad side effects from drugs that are very potent. You can still have them with the less potent ones, but they're not as common. These drugs, we know that they not only shrink tumors, but they allow, they basically stabilize or shrink tumors for a good long while, right? So for sorafenib, that's what we call the progression-free survival, the time that you have no progression. That progression-free survival with sorafenib was 10.8 months. With lenvatinib, it was 18.3 months. So this is what you can expect from, like, you know, patients ask me, well, how long do you think that this will work for? And they're on lenvatinib, I'll quote them the 18.3 months, because 18 months is kind of where, you know, the average patient is able to stay on these drugs for. Okay, lenvatinib has also been shown to work in patients who've been previously treated. So there were patients on the trial that had been on sorafenib, sunitinib, pazopanib, and other kinase inhibitors, and those patients still did quite well. So this can be used in the second line, and we still see some good responses. What we don't know if these drugs really help patients live longer, right? Because what we want is to help patients live longer, but also live better. And we don't really know if they do, because in these trials, patients were allowed to cross over from the placebo arm, if they were on the placebo arm, to the treatment arm. And so we don't really know if there's a survival advantage. There probably is. They have looked at older patients versus younger patients in terms of survival, and it does look like there is an advantage for the older patients on lenvatinib. They do actually live longer. There are some side effects that we'll talk about a little bit more at the end of this talk, but hypertension is a huge problem with lenvatinib. Hand-foot is a really big problem with sorafenib. So, and you can see the whole list there of different side effects for each drug. So they're not benign treatments. You know, some patients, they come and they really want to be on treatment, and we advise against that if they're not progressing or have any kind of significant disease, because the list of side effects is pretty long. We also use these, the lenvatinib and sorafenib. We're very careful about using them in patients who have already very bad high blood pressure, or who've had heart attacks and coronary issues. if they've had problems with their bowels before, they have a wound that's not healed, if they have a tumor that's invading the trachea, the esophagus, or any of the large blood vessels in the neck, and then patients who have who coughed up blood, that's a problem. And then patients with tracheostomies, we've also seen some issues with bleeding. So we're very cautious with using what we call the anti-angiogenics, which is sorafenib and lenvatinib. It also is cabozantinib and vandetanib for medullary. But there are patients that I would not use these drugs in, and so that needs to be taken into consideration. There is a lenvatinib pembrolizumab combination trial that's immunotherapy. They, I believe now the whole trial is closed, and hopefully we have some data on this arm that looked fairly good, but we really are interested in patients who have been on lenvatinib and then this drug's no longer working, and instead of replacing that drug with something else, they add on the immunotherapy, and so that study. That arm is now closed, sorry, but we don't have results yet on whether those patients responded after adding pembrolizumab. But that is one approach. Okay, so because not every patient can be on anti-angiogenic drugs, we've very much are interested in finding other drugs for those patients, other possible treatments. And so what we have some data on is BRAF inhibitors, redifferentiation therapy that I'll talk a little bit about, the NTRK RET inhibitors, and immunotherapy, which I won't have time to discuss. The first study that we did with the BRAF inhibitor was with vemurafenib, and this is published. And we did see some very nice responses. Progression-free survival was about 18 months. We had some nice partial responses of 38.5% of patients had a partial response. And even patients who had been previously treated, like with sorafenib, for example, or lenvatinib, those patients also did well, not as well, which is typical as this in second line. There is a study that unfortunately still has not been published in the literature, but it's in abstract form, of a BRAF MEK inhibitor combination called dabrafenib and trametinib. This one is actually FDA approved in anaplastic thyroid cancer with BRAF mutation, but not in differentiated thyroid cancer with BRAF mutation. And so what they did is that they had two arms, patients that were just on dabrafenib and patients that were on the combination. And the response rates were pretty comparable in the two arms. The progression-free survival, the time they were without progression, was a little bit longer in the arm with both drugs, but it wasn't statistically significant. We actually use this drug a lot in anaplastic thyroid cancer, and we have used it as a way to shrink the tumor before going to surgery to see if you can do a much better surgery. Okay, so redifferentiation therapy. This is has been of interest to us for a long time as endocrinologists because we use a lot of radioactive iodine. And so, redifferentiation, and my boss doesn't like that term, but he prefers that we use like resensitization or something. But basically, you're taking a tumor that doesn't take up radioiodine, and you're giving them some kind of drug to restore that ability to take up radioiodine. And so this has been studied for years and years and years, and really there wasn't anything that was very good until Memorial Sloan Kettering started looking at the at the MEK inhibitors to do this with. And then others with the BRAF inhibitors. And so what I really love about this, the beauty of this is that if the patient takes up radioiodine, in many cases, we're able to just stop the treatment, stop the kinase inhibitor and let radioiodine do its job. And so we're able to take patients off of these kinase inhibitors sometimes for a year and a half before the tumors start to grow again, because that's what happens after radioiodine. After about 12 to 18 months, we start seeing that patients start to progress again. The other reason that we like to do this is because we know that patients that take up radioiodine live longer. And so we don't know that that's the case in redifferentiation therapy, but we hope that that is the case. All right, so this is the study that was done at Memorial Sloan Kettering with the MEK inhibitor selumetinib. So selumetinib was given to 20 patients, and they were able to give 8 patients. 8 patients had restoration of radioiodine uptake. And of those 8 patients, 5 patients actually had a nice response to the radioiodine. 3 of them had stable disease with some tumor shrinkage. Interestingly enough, they noticed that, that 4 of the 5 patients that responded actually had RAS mutations. And so we're very interested in the MEK inhibitors in RAS mutated, differentiated thyroid cancer. These are some really nice pictures. Here's a bone metastasis that didn't take up much radioiodine. And then after selumetinib, lots of really nice pictures that they showed in that paper. There was a clinical trial that was enrolling. It's not enrolling anymore. It just closed earlier this year. And so we don't have results yet on that study. Dabrafenib has also been used to restore radioiodine uptake. This was a very small trial that was done, just 10 patients, but they also did show that some patients were able to take up radioiodine and had tumor shrinkage after the radioiodine. Okay, so other non-sorafenib, lenvatinib choices, so non-anti-angiogenic choices, are the RET inhibitors that both of these drugs, selective RET inhibitors, were just approved this year. The 2 drugs are pralsetinib and selpercatinib. Some of you might know them as Blue 667 or Loxo 292. The selpercatinib is approved for lung and thyroid. Pralsetinib is only approved for lung, but you have to have a RET mutation or a RET fusion. And so medullary thyroid cancers have RET mutations. They're much more common than in papillary, where I think 10% is a gross overestimation of patients who have papillary thyroid cancer. That may be true in pediatric thyroid cancer. In adult thyroid cancer, it's far less than that. But these drugs, boy, do they really do work very well in papillary thyroid cancer. And poorly differentiated thyroid cancer, anaplastic thyroid cancer, we're not really sure. And their side effects are really far less than with the anti-angiogenic drugs. We have seen some issues with diarrhea, very mild hypertension, not too difficult to control, and a little bit of, some patients can get a little bit of nausea and elevated kidney function. We've also seen a drop in white blood cell count, so we also need to be monitoring that. Pralsetinib, they also did a study in thyroid cancer. The ones that are circled there are patients that have papillary thyroid cancer, the dark blue patients. So they had a couple of responses. But again, this is not approved for thyroid cancer. It's only approved for lung cancer with RET fusion. Again, few side effects. They're very, very similar to selpercatinib. And we are doing a study now with selpercatinib, the RET inhibitor, to be used before surgery. The vast majority are going to be patients who have medullary thyroid cancer, but we are enrolling both differentiated and anaplastic thyroid cancer patients with RET fusions. So this is just an example of one of my patients that we gave this to. and he has medullary. And then, you know, this was a tumor that was going to be very difficult to get out because of the proximity to these blood vessels. And then it got much, much smaller here. And then Dr. Zafira was able to take that out. And hopefully that's going to start early next year. So we also have drugs that target NTRK. These are also very rare. The two drugs are entrectinib and larotrectinib. Larotrectinib has some data in thyroid cancer that's specific to thyroid cancer. And so you see here, the blue is papillary, the light blue is papillary thyroid cancer. You know, we don't really see NTRK fusions in follicular thyroid cancer. So I suspect that these have been misclassified as follicular thyroid cancer. They're probably follicular variants of papillary. And not truly follicular thyroid cancers. That we've not published this because we really want to clarify this before we publish a paper that says that follicular thyroid cancer patients have NTRK fusions. And then the orange is anaplastic thyroid cancer. So we have a little bit of experience with anaplastic thyroid cancer. Okay, so side effects. This is a question, these are questions that I get a lot at ThyCa, is how to manage some of the side effects of these drugs. High blood pressure, we just manage it the way we always have managed high blood pressure. We maximize the drugs that you're on. We add drugs, we don't take drugs away. And we do it very aggressively before the patient gets so hypertensive that they end up in an emergency room. And so if you're not checking your blood pressure consistently when you start one of these drugs, you need to be. Hand-foot skin reactions, so these are these calluses that you can get. They're mostly on the feet. People who use their hands a lot, like guitarists, pianists, you know, people who drive a lot for a living can have it on their hands too, but mostly we see this on the feet. And this is actually quite painful. You know, what we like to prevent this from happening. And so we try and make sure that the skin remains moisturized, soft shoes, you know, and see a podiatrist before going on these drugs. And then same thing, if you do get it, you know, soft shoes, moisturize the skin and see a podiatrist. The podiatrist can really scrape off a lot of that dead tissue, and then we can start again with the moisturizing. And sometimes we use a urea cream. These are the creams that we often will recommend. You can get urea over the counter at lower doses, 10 and 20%. You need a prescription for the 40%. Rashes. So fortunately, these rashes oftentimes will go away after a while, but we keep the skin moisturized. Our biggest problem oftentimes, especially with the BRAF inhibitors, is that patients get sunburned, and so they need to protect their skin from the sun. This is actually a patient who's on vandetanib. So this drug's not approved for differentiated thyroid cancer, but it can be quite problematic. We can give some medications for that, like minocycline, and then stay out of the sun, of course. With BRAF inhibitors and sorafenib, we see these growths on the skin. Some of them can be precancerous, and some moles that start to change can actually be cancer. So we ask patients to see the dermatologist very early on, and to continue being followed and have these taken off as needed. Mouth sores are really difficult to deal with. We ask our patients to avoid really pungent foods, spicy foods, foods that are very hot or sour. And then we can have them use mouth rinses. So these are some of the things that we recommend, but I'm not going to go over all of them if you want to just take a quick picture with your phone. Diarrhea is also you know, a problem that we see with these drugs that sometimes is manageable with just dietary changes. Sometimes we require over-the-counter Imodium. I usually tell my patients, just have Imodium on hand before you start so that you're not having to run out with diarrhea to go get Imodium. So we like to have them pick that up before they start. We can also add some other medications that require prescriptions. And then some people like to use this Metamucil mixture. I've not used it much, but I've had people say that it really works for them. Fatigue, we always want to make sure that the TSH is not elevated, because some these drugs can cause elevated TSH. We mostly, when we've ruled that out, we mostly tell patients, hey, you're going to have to probably take a little nap at 2 p.m. Make it short, no more than 30 minutes, because then you're not going to be able to sleep at night. Light exercise can sometimes be a problem if you have the calluses on your feet, the hand, foot. But if you don't, exercise does help. Weight loss is probably the most difficult of all of the side effects to manage because lenvatinib causes severe changes in weight, and patients that have been on these drugs for years, sometimes we just have to hold the drug until they gain some weight and then restart again. So patient education is really important. Really, before you leave the clinic with a prescription for these drugs, you should be given some patient education material, or if not, then you should be reading up on it before you get started, so you know what to expect, and things that you can do to help. So, for example, self-monitoring your blood pressure. Pick up a blood pressure cuff at the pharmacy. Have Imodium on hand, things like that. Know who to call after hours if you have a problem. So anyway, this is our anaplastic thyroid cancer team. We also take care of advanced differentiated and medullary thyroid cancers, but I'm just showing the team here.
Well, thank you again for all the time you spent with us, and for the wonderful information that you always bring.